हाँ महेंद्र मैं शुरू कर रहा हूँ, एक बार चेक कर लो, ऑडियो वगैरह चेक कर लो। Okay, so good evening everyone. So I think I'm connected and we should start our discussion. Okay, so fine. So basically you see, this year INICET surgery question was little unusual. Some questions were very basic like FMGE level question. Some questions were kind of out of textbook, but overall a good paper. So this was one question, identify the incision made and marked in the image. Not the same image. The image was not same, but the site was same, a oblique incision in one area. This is a Gibson incision, and I'm not very regular on Facebook, but this very year, this was one of my posts in Facebook where I described Gibson in Damn Exclusive Club. I described modified Gibson incision. So basically, if you see, Cocker's incision is a right subcostal incision, that's for gallbladder. Theodore Emile Cocker, the first surgeon who got Nobel Prize. He got Nobel Prize for thyroid surgery, but Cocker incision of gallbladder is after him, named after him. Paramedian incision extended upward is Robson incision. A transverse suprapubic incision, muscle cutting, it's different from phalangeal. Phalangeal is not muscle cutting and much lower, it's above the phalangeal. Transverse muscle rectus cutting is Thompson, is Millard. And Gibson incision made here is the most preferred incision for renal transplant. Basically, we start the incision 3 centimeter medial to ASIS here, 2 centimeter, 3 centimeter above the inguinal ligament like this up to the lateral border rectus. This is a very good incision to reach lower ureter for renal transplant and some gynecological surgery. So this basically is a Gibson incision here, and they have asked the question, giving an image that what incision is this? Of course, was a Gibson incision. Now, this is second question, in which of the following case liver transplant is possible. This also is direct question from the notes, what we discussed. So, when I discuss colorectal cancer, very clearly I tell that only one adenocarcinoma of GIT liver secondaries are operable. Of course, it's operable in carcinoid, neuroendocrine tumor, endocrine tumor of pancreas, in endometrial cancer of uterus, and also in adenocarcinoma colorectal cancer. Colorectal cancer adenocarcinoma, the margin should be 1 centimeter at least, and the functional liver should be more than 30%. So, if these criteria are met, you can do primary resection of the secondaries to the liver, and if liver is not functioning, kind of cirrhotic patient, etc., you can even plan liver transplant. So, out of all adenocarcinoma of GIT, only colorectal cancer liver secondaries are considered operable and liver transplant can be done. This also is a direct question from our discussion and notes. Now, a patient underwent cholecystectomy, his histology reveals carcinoma with invasion to muscular. This is T1B. Now, this is a question of this very year TND in DAMS. This question I discussed TND GIT, including liver, gallbladder, pancreas. So, this is a question from one of my TND where I discuss gallbladder cancer, staging and treatment in detail. You see, TIS is carcinoma in situ, T1A is lamina propria, and in these two, we only have to do cholecystectomy. Earlier, port site excision was done. Now we don't consider port site excision as an important step. That is totally optional. So this question I kept because the answer has changed. Earlier it was port site excision. Now it is just follow up. This is the new answer. But once muscle is invaded, that is T1B, you have to go for radical cholecystectomy. You should remove some liver along 2 centimeter liver margin, wedge section with this. T2, that is perimuscular tissue, not invading through the serosa, and T3 outside serosa or one organ involved, and T4 is surrounding such a 2 organ or vessel involved. All these cases you do extended cholecystectomy. And by extended we mean we remove liver, like this is the, let me draw it here. So we remove gallbladder along with all less omentum, all lymph node here, segment 5 and 4B of liver. This complete is called extended cholecystectomy, and that's only done when the cancer is T2 or beyond. Even T1B one can do extended, but generally we do radical, where we take 2 centimeter margin of liver, and that's sufficient. So in this case it was muscle, so naturally we have to go for radical or white excision fossa, where we take 2 centimeter margin around the gallbladder into the liver. Gallbladder cancer is radio resistant, no role of radiotherapy, and chemo resistant. Chemotherapy is given as an adjuvant, not as a neoadjuvant, as an adjuvant gemcitabine 5FU combination, but it's not a very chemo-responsive tumor. Post-orchidectomy, the specimen shows Rinke crystal. Rinke crystal are intracytoplasmic rod-like crystal, and they are characteristic of Leydig cell tumor. Leydig cell tumor is a testosterone-producing tumor. It has a bimodal pattern. One peak is within 10 years, and within 10 years a tumor producing testosterone will of course cause precocious puberty, and later on after 40 years you can also get this. It's usually benign, 80% benign. So 3 inclusion body in testicular tumor. One is Rinke crystal, rod-like cytoplasmic crystal here. Second is Karl-Exner body that you get in yolk. Second is Schiller-Duval body that you get in yolk sac tumor. In the center there is a vessel all around malignant cells, a primitive yolk sac. So Schiller-Duval, this also is an old MCQ. Remember this will be repeated definitely. Schiller-Duval body in yolk sac and Karl-Exner body in granulosa cell tumor. In the center, pars positive hyaline all around nucleus, coffee bean shaped in the cell. This is granulosa cell tumor. So these 3 inclusion body, granulosa cell tumor in Karl-Exner body in granulosa cell tumor, Schiller-Duval in yolk sac tumor, and Rinke crystal in Leydig cell tumor. This they do ask very frequently. One more nodule in testis. This is not yet a question, but maybe in future they'll ask this. Pick's adenoma. Pick's adenoma is a benign nodule of Sertoli cell, seen in certain benign condition as well as in undescended testis. So this is a sclerotic tubule and Pick's adenoma, that is a Sertoli cell nodule. Tumor marker for seminoma. You know the 3 tumor that we order in testicular tumor. One is alpha fetoprotein, AFP. This is basically high in yolk sac, in 90% yolk sac. Other than yolk sac, it can be high in embryonal cell cancer and teratoma, 30% embryonal cell cancer. Second is beta HCG. This is a marker of choriocarcinoma. Choriocarcinoma, 100% beta HCG is high. Choriocarcinoma. And 10% seminoma beta HCG is high, because 10% seminoma have syncytiotrophoblasts, rest have cytotrophoblasts. So all seminoma having syncytiotrophoblasts can have high beta HCG, only 10%. And alpha fetoprotein is never ever high in seminoma. If you have a tumor where AFP is high, it cannot be pure seminoma, it has to be mixed tumor. So AFP is basically a non-seminomatous tumor marker, AFP. It's never high in seminoma, okay? It's basically for yolk sac and really for embryonal cell cancer and teratomas. So, So AFP for yolk sac, embryonal cell and teratoma. Beta HCG for choriocarcinoma mainly, really seminoma. LDH is the marker for seminoma plus placental alkaline phosphatase, which is a bulk marker. This is also for seminoma. Even CD117 can be really high, but that's not considered good marker. We don't do that. Placental alkaline phosphatase is the answer for main tumor marker. Second will be LDH. That's not an option. Had it been an option, that would have been a better answer. But here answer is PLAB. These are the main answer. Now, let's come to next question. An ulcerative lesion noted near the nose. You see, when you draw a line from the ear to upper, angle of mouth, upper lip, this area is the known area for rodent ulcer or basal cell cancer. Earlier, there was a huge difference between FMGE level and INICET, AIIMS and PGA level. Now, I see the level is becoming narrower and narrower. This was a question of 2021 FMGE, foreign medical exam. They showed an image and asked what it is. The answer, of course, was rodent ulcer. Here also the answer is basal cell cancer. What all features they ask in basal cell cancer other than sight? Sight means draw a line from ear lobule or tragus to angle of mouth above this, in this area. Most common sight, medial cancers of eye or can be around the nostril. You see, basal cell cancer first is rolled over border. Second point, waxy papule, waxy appearance and central depression. Third point, pearly white appearance. And fourth point, telangiectasias. So these are the four features. I'll show you the image as well. And these are rare finding, but you may get. So, see, this is a pearly appearance, like a pearl. This is telangiectasia on the surface. Rolled over border and central depression. These are the classical feature of rodent ulcer, which they do ask. Another point is, out of all variety, morphia is most aggressive. Morphic variety or morphia, which appears like a scar, not like a nodule, appears like a scar. It synthesizes type 4 collagenase, so it spreads more rapidly. That's another question they ask. Which type of basal cell cancer is most aggressive? Morphia variety. Another question, what biopsy you take in basal cell cancer? Shave biopsy. Not incisional, not excisional, shave biopsy. So these are the questions they ask in basal cell cancer. Shave biopsy you do. Morphia is most aggressive. The features are pearly white, translucent, telangiectasias, rolled over border, central depression. And of course, an image of a rodent ulcer or basal cell cancer near the medial canthus of eye. This is classical basal cell cancer image. Now, yeah. So, sorry, I'm having little common cold and sore throat, so apologies. The fibers of internal oblique and transabdominis contribute to which component of inguinal canal? You see, this is ASIS, inguinal ligament, pubic tubercle and rectus. The anterior wall of inguinal canal, external oblique forming the external ring. External oblique is the anterior wall. Laterally, here will be the internal oblique. So, inguinal canal extending from deep ring to superficial ring. Anterior border is external oblique and internal oblique only laterally. Roof, transverse abdominis coming here, they only form the roof, not the anterior wall. So, transverse abdominis and internal oblique, they form the roof, which is the answer. Now, they go behind. So, posterior wall is formed by fascia transversalis, but medially it formed conjoint tendon forms the posterior. These two form conjoint tendon, which goes medially. So, you see, this is the anterior layer, external oblique, and here will be internal oblique, both forming anterior. This is the roof arching fiber of transverse abdominis and internal oblique both, and then it is the conjoint tendons forming the posterior radius plus fascia transversalis. And the floor, the inferior, is formed by inguinal ligament, but medially, here you have lacunar ligament also. Inguinal and lacunar. Lacunar ligament is only medially. So, floor is formed by inguinal ligament and lacunar ligament only medially. Posterior wall formed by fascia transversalis, but medially we have conjoint tendon. Anterior wall is formed by external oblique aponeurosis, but laterally we have internal oblique as well. And roof is formed by arching fiber of internal oblique and transverse abdominis. So, obviously, answer here is roof. Yeah, can you tell me the option set? The options I got in liver transplant were the option like this. But of course, I did not give the exam, so I do not know exactly. This is... No. I'm pretty sure that rectum was the option there. Even liver secondaries from breast is also operated. So, if rectum is not an option, this you replace by melanoma or other, then out of these four, breast is the best answer. endometrial cancer, neuroendocrine tumor, colorectal cancer, pancreatic endocrine tumor, really breast cancer, you can operate. But breast is not a good option. Testicular liver tumor are not operated. RCC liver tumor are not operated. You can do palliative radiofrequency ablation, but not a curative resection. Melanoma, it's not operated. But I feel, because I have checked with many students, they all said rectum was the option there. Incorrect statement about choledochal cyst. Choledochal cyst increased risk with cholangiocarcinoma. This is absolutely correct. There are 5 types. I'll tell you something which probably have not been taught to you. Type 2 and type 3 do not have cancer risk. Only 1, 4, 5 have. And 1 is the most common type. So this is a correct statement. But 2 and 3 do not have cancer risk. Option were multiple choice. Here, so they contribute to roof and posterior wall both. If multiple, Manoj, multiple was the answer, then these two form the conjoined tendon and they go posterior also. So, Manoj, Gopinath, if multiple answers were correct, then B and D both are right answer. If only one option you have to mark, then roof is a better answer. Okay? Right. So, cyst is opened and drainage. This is never done. This is not the treatment. Treatment is excision of cyst plus Roux-en-Y hepaticojejunostomy. This also is a question from TND. We have this question in TND. Todani is used. I'll discuss that. And anomalous biliopancreatic junction again is the right statement. So Todani basically is when we have a cyst in the bile duct, you call it type 1. Type 2 is a diverticulum. Type 3 is a choledococele. This is treated by ERCP and incision. Type 4 intra and extrahepatic cyst A, only extrahepatic B, and type 5 is intrahepatic called Caroli's disease. Another question frequently asked is central dot sign. Central dot sign in Caroli's, that's a sign in CT scan. So in type 1 you have to excise the cyst along with the gallbladder and Roux-en-Y hepaticojejunostomy you never drain the cyst. You don't even drain the cyst into the duodenum due to the risk of ascending cholangitis as well as cancer. So obviously answer is B. And this is the anomalous junction where the common junction is long, which precipitates. This is called Bobbitt hypothesis, not for you, you can skip the name. But when you have anomalous junction, the pancreatic juice goes into the bile duct. That is considered one of the risk factors for choledochal cyst. Classification of bile duct injury, taking location and thermal injury into bile duct and vessel into account. You see, this question I would say is a very, very useless question to ask from undergraduate student. We discussed bismuth 15 years ago. Then we switched over to Strasbourg 10 years ago. Then a new classification came, Stewart way, which is not yet being asked. Hanover is a relatively new classification which is not followed in India or not given in your textbook. So it is not fair to ask Hanover from MBA student. Unfortunately, the answer for this is Hanover, where vessel is taken into account, which is why Hanover is the answer. Bismuth is only a stricture. How much length of common hepatic you have? So, right and left and common hepatic length preserved more than 2 cm, then we have stricture A, type 1. When you have less than 2 cm length, type 2. Don't have common hepatic length, but the junction is preserved, 3. Junction is gone, 4. And posterior stricture duct, 5. So, bismuth is only for stricture. Strasbourg had stricture, transaction, leak, all. But Hanover includes the thermal injury, transaction and vessel, all 3. The detail is not needed. You can skip the detail part. and even this is much beyond your course, but still you can remember this, that only peripheral leak is type A, where cystic ductus leak or gallbladder fossa leaking. Type B is a stricture. Type C is a lateral injury but only partially, and type D is a complete transaction. C and D has vessel injury as well, and E is a stricture. So A is leak, lateral leak. 2 is clipping, that stricture clipping. C and D, they have lateral injury, transaction plus vessel, and E is a stricture. So unfortunately, this is not in your textbook. Stewart, Way and Strasbourg we do discuss, but Hanover we don't discuss. Unfortunately, this was asked because vessel is there, so Hanover was the answer. Only remember the name and only remember this. You don't have to know the detail. You can skip this part. This will never be asked. Which is not a risk factor for gallbladder cancer? Again, this is a TND question I kept this year. This very year, we discussed this in TND batch, all centers. A 12 millimeter polyp, what you will do, and I told them that less than 10 millimeter has no risk of cancer, more than 10 millimeter has a risk of cancer. So here the answer was cholecystectomy. Here the question is what is not a risk factor. Porcelain gallbladder has a 10% risk. Although it is not an absolute indication, earlier it was absolute, today it's a relative indication. The risk is there but not very high. Primary gallbladder, yes, there is a risk. Polyp, more than 10 is risk, and gallstone more than 3 is risk. This is not a risk. So less than 10 is not a risk. Other than this, Clonorchis sinensis and Opisthochus are also two worm, also risk for cholangiocarcinoma. Typhoid carrier is another risk. Thorotrast and other dye and some drug is also a risk. Ulcerative colitis is also a risk. So, most important factor for CA breast, well, most important overall is stage, if that is answer. In single factor, most important is node. After metastasis, it's ER-PR status, and in recurrence, it is the duration when the cancer appeared after the treatment. This part I'm sure nobody tells you, and it's not a question yet, but you never know, in future you may get a question. So in a recurrent case, the most important factor is duration. After how many months and year the recurrence is there. So overall stage, single most important node, which is the question here. In metastatic cases, ER-PR status, and recurrent cases, the duration after the treatment. In this case, the answer is A. In emergency, open cardiac massage. Open cardiac massage, you don't maintain the sterility. It's an emergency. So obviously, it will come in the contaminated wound. Clean means you are maintaining the sterility. That is hernia, thyroid surgery, cardiac surgery, breast surgery, etc. Clean contaminated, the sterility is breached but in a controlled environment. Like I am doing dissection osmosis, I apply clamp and then I cut. So apply clamp, then cut. It's not spillage. Uncontrolled spillage is contaminated. So where the sterility is not maintained, uncontrolled. So here you are doing emergency surgery, cutting and putting your hand in and doing massage. So it is contaminated. Dirty means already like necrotic tissue, abscesses, etc., perforation, etc. So this is a contaminated wound. This again is a simple question, this Wallace's rule of 9. This I think all of you must have marked it correctly. 9 head neck, 9 anterior chest, posterior chest, abdomen anterior, abdomen posterior, 9 upper limb, 9 thigh, 9 leg, 1% perineum and genitalia. So they are saying that the anterior chest abdomen, so only anterior, 9 and 9, that will be 18. Upper limb, another 9, and lower thigh, another 9. So 9 4s are 36. So answer is 36%. A simple question, straightforward question. A young female presents with pain and vomiting in emergency. Clinical examination reveals a swelling lateral and below. Lateral and below means this is the pubic tubercle. If the swelling is lateral and below, of course, it is a femoral hernia. Obturator hernia is also here, little lower down, little lower than femoral, but that's away from pubic tubercle. If relation of pubic tubercle is given, we'll go for femoral hernia. The direct, indirect and direct hernia will be superior-lateral to pubic tubercle. The indirect hernia will be superior and lateral, direct hernia will be superior and lateral, only femoral hernia will be inferior. So obviously the answer is femoral hernia. It's a simple question. I don't think there's any confusion here. A female Melanoma is very aggressive. Melanoma going to liver, it's inoperable. Only palliative. A female patient presents with non-palpable lump in the breast. Biopsy shows luminal type A. What is luminal type A? ER positive and or PR positive, HER2 negative and low proliferation index. What is low proliferation? Ki 66 less than 14%. So here the answer is B. No, HER2, yeah, B. If ER-PR positive and high proliferation index or HER2 positive become B, and only HER2 is, so here luminal A, luminal B, ER-PR positive but proliferation index is high or HER2 high. Only HER2 is HER2 expression, all negative is triple negative. Today triple negative has a worse prognosis because of trastuzumab, which gives good response. Overall, this is the best prognosis. Trastuzumab you will give for type 3, HER2 positive. A neonate who is breathless found to have, I am not sure whether this question was asked or not, because one student told me this question, others didn't say this. So breathless found to have scaphoid. A scaphoid abdomen breathless is most likely a diaphragmatic hernia where positive pressure ventilation should be avoided. You gave membrane oxygenation, not positive pressure. So obviously, I am not sure of this question. It's an old question, simple question. All are true about adrenal gland except this is the right kidney, this is the left kidney is higher, right kidney is lower, but right adrenal is higher as compared to left adrenal. Why right adrenal is higher although right kidney is lower? Because of the shape. Right adrenal is triangular, left adrenal is concentric. Due to triangular shape, which I discussed in urology, at some centers I have taken urology, I told them this point, that right adrenal is triangular in shape, left adrenal is concentric, weighing 5 gram each, length 531. 5 millimeter, 3 millimeter, 5 centimeters, 371. In children, the adrenal is much bigger, 1/3 the size of kidney, but as the person grows, it becomes 1/10 the size of kidney, it becomes smaller. So, right adrenal is triangular, left adrenal is concentric. The blood supply comes from 3 arteries, inferior phrenic aorta and renal artery. Venous drainage only by 1 vein, right adrenal to IVC, left adrenal to renal vein, left renal vein. So, yellow in color, yes. Close to pancreas, left of course. Right is close to liver. Left, right adrenal, semilunar. Semilunar is left, right is triangular, pyramidal. And retrieval organ, of course, it's retrieval organ. So these were the questions which I could gather. If you have any other question or any other doubt, feel free to ask. Surprisingly, 2 questions from testis, both are very basic questions. 2 questions from breast, again basic questions. So questions were little unusual, and 2 questions from gallbladder, again but overall questions were not very difficult. So any question you want to ask here? So I think that's it. I don't see any question. I'll wait for 2 more minutes. This is a classical question where the scaphoides abdomen and the heart will be shifted to right side. That's another hint they give, although in this question it was not mentioned. If rectum was not an option, sorry, Aflatun. If colorectal cancer was an option, that's the answer. Both are not an option, then I would go for breast cancer. Seminoma question multiple, Srihari. Then in seminoma, if multiple answers were correct, then the answer would be PLAP. This definitely is high, and in 10% beta SEG is also high. Although this is not considered a marker for seminoma, it's considered a marker for choriocarcinoma. So if in Viva I have to answer, probably I can justify beta HCG 10% high, but I think only PLAB should be the answer here. Had LDH been there, I'll definitely go for LDH. I'm not sure LDH was the option or not. KIT can be high, but we don't use KIT as a marker for seminoma. CD117. So that's it for today's session. Although I wish all of you a very best of luck and good result, but still you have NEET. Very near future you will have NEET. So don't lose your focus. Remain focused, and I'm sure you will do very good in NEET. So all the best to all of you.